We are talking about maternal health this morning. A panel of three: Dr. Edward Serem, the head of the Division of Reproductive and Maternal Health, the Ministry of Health; Dr. Pamela Godia, a public health specialist; and Honorable Esther Okenyuri, a nominated senator who sits at the Senate Health Committee. And before we went on break, Senator, I just wanted you to quickly just react to what Dr. Serem described as what is included as part of the strategies to tame the teenage pregnancy crisis. And I heard him say categorically that contraceptives should not be given to those who are under the age of 18. Do you think this can work under the current setup?
Like I earlier mentioned, we are generally conservative. I am personally conservative, and I share some of his sentiments. But the realities out here are not what we would wish. That ideally, these young people below the age of 18 years should not be using contraceptives. But if you go to most of these pharmacies, what do we call this morning after pills? They are being consumed in very large numbers by young people in campus, in high school. And we are still saying, yeah, we do not want them to use. But they are using. The reality is that they are using. Maybe now what, as a ministry, we need to look at is how to discourage these young people from using these contraceptives, because they have long-term effects. Especially research has shown for people who are using these morning after pills, later when they want to conceive, when they are now way older, they want to conceive, they are going to experience problems. So I think I would want to differ a bit on, in as much as, yes, I wouldn't want these young people to use contraceptives, but the reality is that guys are using those pills over the counter without looking at the long-term effects of this. So Dr. Serem, I think on that one you need to relook a bit. Because the reality is they're using them.
They're already using it.
They're already using them. Harmful ones. Right. And over the counter, that's one issue I actually want to look at the Senate. How safe are the drugs people are getting over the counter with no information on what the long-term effects would be? What kind of information is available to the public? Like the other time we had a discussion, sorry to bring that here, we had a discussion on GMO debate, and, people are like, yeah, we do not want, but the reality is that we've been consuming GMO products. What the issue is, at least give people an alternative on what to pick, or if they are picking, it should be, well, they should have the knowledge that whatever I'm picking is GMO. So the same thing with this contraceptive issue we are having. There should be enough information first to the public. And as he said, I think they need to relook on the issue of making it no, they are not using, because the reality out here is that they are already using.
Thank you.
All right. Dr. Godia, coming back to you, if you look at this issue of the confidential inquiry on the maternal deaths, I just want to understand from what you gathered, why is it important? What will it inform in terms of how we are addressing this particular issue in our country?
Okay, so thank you very much. May I make a comment?
Yes, go ahead, please. Yes,
on the teenage pregnancy. Based on the data that we have, we see that close to 250 women who died between those 5 years who were below 20 years old. So the young girls 20 years and below are also dying because of pregnancy and childbirth, and some of them it's their first. Of course, it's their first pregnancy. So they get their first pregnancy and they end up dying. So we need to address these issues. One of the other factors that I would want to talk about is the time these deaths are happening within our facilities. So you find that we find that majority of the mothers, close to 3/4 of the mothers, they die outside working hours. outside working hours and on weekends. And we know what happens outside working hours and weekends with regards to the staffing. You find that during that period of time, we have very few staff on duty. And especially the specialists will not be working over the weekend. So having this data and sharing this data with the Minister of Health, because this data is not data that we did it alone with support from Liverpool School of Tropical Medicine. It's data that is collected and the files are reviewed in collaboration with the staff of the Ministry of Health and Dr. Serem's office. The report gives an opportunity for engaging, starting discussion around what is killing our mothers, and if we have to address what is killing our mothers, we have to target, or we have to put interventions that are going to have the greatest impact with minimal resources. So we've talked about allocation of budget to health, to the counties, and you find we don't have enough resources. Resources are not enough, so we have to be very smart when we are putting our interventions in place. So sharing this information also helps Dr. Serem and his team to just ensure that where are we putting our money? Where are we putting our money if we have to have a greater impact? And as you said, as we've discussed earlier at the beginning of the show, the rate of reduction of maternal mortality in this country is not at par with what is required in order to meet the global targets. Because we are saying that our maternal mortality over the last 20 years, we've had a 40% reduction from 590, which was in 1998.
Yes.
Yeah, to 355. Those are close to 20 years. So we've had a 40% reduction. And if we have to move from 355, where we are at the moment, based on the census report, Dr. Serem, 2019 to 2019 census report, to 70 deaths per 1,000 live births, which is the global target that countries should strive to reduce their maternal mortality from the figure they have to less than 70 per 1,000 live births. So you see, we have a lot of, that's like an 80% reduction from 355 to 70. 80% reduction over a period of 10 years. So we know that, putting two and three or 1 and 2 together, is it a target that we are likely to meet in 2030?
Okay.
Yes. So I think this kind of information is important for Dr. Serem and all the other stakeholders who are working in health, because you find that Ministry of Health is the major player, but we also have other players who come in. We have development partners who come in to support maternal health. We have other NGOs who are working to support maternal health at either national level. They support the policy review process, and we also have other partners who support the specific health facilities and also at the community level. So it's a way of informing the policy direction on where the priorities are. Because as Dr. Serem will be reviewing his annual work plan or his strategic plan, he'll say, okay, let's put our resources in addressing hemorrhage or in addressing hypertensive disorders, so that we know that healthcare workers who are at the front line are able to deal with all these emergencies as they occur.
And you have placed a lot on Serem's table.
Yes, he's a major stakeholder.
He's a major stakeholder, but we support him. Yeah. He's not alone.
Yes.
So I'll ask him, Dr. Serem, so what are you doing to realize this target? Because it's all our desire that we save the lives of our mothers, we save the lives of our children. And if you look at how the trend has been, and even Dr. Godi has talked about a 40% decline over several years. I just earlier said that it's a 7% reduction from between 2014 to the year 2022 in terms of the maternal mortality ratio, which, if you ask me, is snail-paced. What have you identified as some of the reasons why we are having such a sluggish process in reducing the numbers of those who die just before, during, or after giving birth?
Thank you very much for that. One key issue on that intervention is, of course, improving the finances. As we have said, as a country, of course, there are a lot of concerted efforts being made to make sure that health receives more funding, because it is the finances which will drive the issues of human resource. Because for you to reduce maternal mortality, the human resource who are skilled have to be capacitated and have to be empowered, because they will be in a position, because we are now talking about issues of emergencies most of the time. Somebody delivers, and as we all know, death happens within the first 24 hours. So we are talking about now capacity building and improving the numbers of health workers, and I think that is a part of the current government agendas, making sure that you bring you increase the number of health care workforce. That one, and the other one, of course, is improving the infrastructure. And I'm glad Senator is here, and we've seen a tremendous increase in the number of health facilities in the whole country. Looking at about 5 years ago or 8 years ago, we have seen an increase in the maternities, or where the women can deliver. And we want to encourage the women to deliver, because when they deliver in the hospitals, in the health facilities, that you will reduce the maternal deaths significantly. And it's a gold standard. We don't want women to say, okay, we can deliver at home. No. The standard is to live. The other issue, of course, is...
Before you proceed, Dr. on the other issue, because you have mentioned this, and just in appreciation of that, the percentage of women giving birth in the presence of skilled birth attendant has almost doubled from 37 in 2017%, that is to 69.5 in 2021, according to the Kenya Health Information System. But when you talk about personnel, as you have talked about human resource, isn't it contradictory then, of course, as a government official, that you have more than 4,000 doctors who are unemployed, and some of them specialists here and fall within the bracket? They are looking for greener pastures outside the country, and literally an egg on the face of the government that the government is unable to absorb such specialists and doctors who otherwise would have even lessened this number further to the desired standards under the Abuja Declaration.
I think that's an issue which is being addressed. You know very well that we are in a new administration, and a lot of reforms are still going on. And of course, employing such number of doctors, of course, and it's not only the doctors who will make a difference in reducing the maternal mortality. We are talking about the nurses, we are talking about the clinical officers, and all these contributes, because as a country right now, I think we have almost like 30 or 40,000 nurses, and they are actually the drivers in making sure that they are the midwives, and they are the ones who actually contribute to the reduction of the maternal mortality. So I think that is something which it could be beyond me, but I know what that a lot of discussions are going on to make sure that we improve on the health worker population ratio. So I think that is one of the key issues which are going on. And
I want to support...
Just hang on, let me finish, and then you will proceed. Yes, go ahead, please. Finish up, Dr.
Yes. So, and then I've mentioned about the issue of infrastructure, and I've mentioned about the issues of finances. The other ones are, of course, commodities, life-saving commodities. And, of course, also now with the issues of UHC, of course, you are aware that NHIF has been renamed NSHIF, a National Social Health Insurance Fund, and so there is some reforms which are going on there, and I'm sure all these coupled together will improve issues on deliveries. So with this, therefore, we also want to look at the issues of blood, because apart from issues of oxygen and I think during COVID, we saw a lot of, most of the health facilities had improved the infrastructure on delivery of oxygen. Remember, blood and oxygen are also very key. And that's why we encourage women, you deliver in the hospital.
But,
yes?
But how will they do that if the very live example that the Senator gave us earlier, 2 nurses attending to 200 women a day just here in Nairobi at Pumwani? How will that woman in Garissa or Wajir or Makueni in the remotest village get that assurance that they will be attended to at a health facility, which they probably have to walk several kilometers to get to? I mean, these realities, Dr. Serem, are we looking at them when we're giving such assurances to the nation?
Everything is progressive. Okay, you know, you may not achieve 100% in a short while. And we are saying that, I mean, from where I sit and the discussions which are happening is that there is a concerted effort. That this is now, we are now addressing those issues. We know now, like now, the Hassel regions. Yes, they are actually, I mean, the first areas, the facilities are far, and of course, you know, the issues of insecurities and all those kind of things. All these things are being addressed, and all these things are progressive. The intention is good. I think that is what I have to say from the government.
I actually wanted to note that while I appreciate those challenges, we have so many challenges in most of these sectors. But I think it's also good to note that it's the priority of any government to have their mothers deliver in safely and, you know, in comfort for that case. And I've been seeing, you know, our priority as the Kenya Kwanza government in the bottom-up economic model that we largely campaigned on was to have access to healthcare, Kenyans having access to healthcare services. And I think the government has rolled out programs that are building up to that access to healthcare services. Now we are anticipating the government to get more healthcare workers, 20,000 healthcare workers to support the initiatives that are already happening. You see there are reforms at NHIF. The government has also taken a deliberate move to continue with the universal healthcare that we are seeing. So I saw this on the budget policy statement we were looking at the Senate yesterday.
So in as much Linda Mama, was it in any way impacted in this transition phase?
Yes, the government has continued with the Linda Mama program. And why I'm saying, in as much as we have those challenges also, we cannot purely look at the challenges only. We also have to look at what the government is doing. And me as one of the people who are on those caravans campaigning on that platform, feel like we are already having this conversation. The government, from the proposals that were brought in the new budget we are seeing, is displaying goodwill to want to support this sector, serve Kenyans better from those proposals I'm telling you. And we as citizens at our own capacity will engage in maybe civic education to talk about some of these issues you're raising and the worrying statistics. But I still would say the line ministry and the relevant persons still have to implement the proposals that are being brought forth by the government. But on the side of citizens, surely I think we are doing our bit by informing the public what they are meant to be doing to support the initiatives that the government is laying. Yes.
Okay. Right. Thank you. Dr. Serem, coming to you now, Dr. Pamela Godia, of course, this will have a flowing effect to the Daktari as well, Dr. Serem. You earlier on talked about the place of data and the collection of the same in the reduction of cases that we are recording at the moment. One of the issues that is of concern is that the civil registration system does not often align in terms of extrapolation of the needed data. And the challenge is that you have the census that normally happens after a decade. The next one will happen in 2029. Sure. Therefore, it's a long period of time and no track on the numbers of home deliveries where cases of mortalities are not recorded as required. Dr. Then from your recommendations in your report, what then do we do to streamline our data collection, even as we focus on the reduction of maternal mortality cases in the country?
Mm-hmm. Okay, so thank you so much for that question. I think I'll talk a bit, and then Dr. Serem can respond further, especially with regards to what's going on in civil registration. So it's always been a challenge to identify a maternal death, to say, especially in the community. And you've said clearly that we have a significant proportion of mothers who are also dying in the community. So having that data feed into the civil registry has always been a challenge. And you find whatever information that is available at the chief's place, because that is the local area where certain data is collected on the births and the deaths, especially at the community level. So you'll find sometimes there's improper, inaccurate reporting of a maternal deaths, because for you to identify a maternal death, you have to know that you have to ask some questions. Like is this woman of a reproductive age group? Yes or no? And was this woman pregnant? Yeah. And sometimes, if for the young girls, as you've said, they might not indicate that they are pregnant. Yeah. So people they might not tell anyone that they are pregnant. So it will appear like any other death of a young woman that has taken place. And as you said, when it comes to issues of abortion, you find that because of the stigma that goes with it, that reporting might not be very accurate. So I think there's some progress with regards to looking at the civil registry and trying to link the information within the health sector and that within civil registry, so that they can marry each other. But I think it's a long way to go. I think there's some progress towards digitizing community health information system that is going on, and seeing how that can link both to the Ministry of Health data and also to the civil registry. But I think maybe Dr. Serem can add on that, but civil registry is also something that it's being worked on to...
Yes, Dr. On the data collection and the streamlining of the systems.
Yes, thank you very much for that. The Ministry of Health has already embarked on digitalization of information, and this one will cut across the country. That we now, a server is being installed where all the data, all the information which is available in the country is adequately analyzed and put in use. I think we have been having some issues of, inaccurate data here and there, but digitalization now, so I think that system is going to be launched in the near future. And so on the same note, going back, as you mentioned on issues of maternal mortality, of course, we had the census report in 2019, and we're expecting another one. Unfortunately, KDHS didn't have the sample size, didn't have the threshold to bring issues of maternal mortality. And if you look at that, the latest KDHS report of 2022, it didn't have maternal mortality because the threshold. We are not talking about 355 deaths per 100,000. But of course, the sample size for KDHS was, I think it was about 40,000. So it couldn't give us the results. But I think, of course, there are also discussions on how can this one be shortened so that we don't have to wait for 10 years so that we get this data. Like now, if we are now talking about 2019, right now we are in 2023. Now it's now 5 years. We don't know what has happened because we are putting a lot of interventions. Maybe a lot could have happened, and I wish there will be some innovations to look into and see how else can we get this data so that we see the trends in which we are moving. of course, confidently, I will tell you, as a country, we are making progress in reducing the maternal mortality.
Okay. But there's also one concern before my colleague Safi comes in here, and that is since 2000, about 23 years ago, the starting of the program to improve public health by the training of personnel and trusted local community members who in this case are volunteers of information and seek also information, educating, creating awareness amongst the people. And twice a day within the village setup, educating in terms of giving information about primary health care. Again here, you have a personnel that is underpaid, about 8,000 Kenya shillings, that's about $66 in the current rate. Already there is a deficit of 7% in meeting the declaration we sign as an entity, a signatory under the Abuja Declaration as the government, and you look at the national budget for health. Again, the other concern, which is the multi-layer, is that all functions have not been let go by the government in terms of healthcare, and that there are some functions that the national government is still undertaking. How do you address those three complexities that, if not addressed, stand in the way of not lessening these numbers as required as per your projections as a ministry?
Yes. One thing which is very clear on this is, UHC, as this one has been highlighted by the president, is anchored on primary health care, and that is now the shift. That UHC, we have to look at more on the preventive as a primary health care. On this, therefore, remember, we are already strengthening the community health workers. And we already have community health assistants who are in charge, and we will therefore want to improve that. Of course, there are issues of payments. Yes, community health assistants are already under government pay. And I'm sure there are discussions on how they can be better facilitated. Remember, the projection for raising money for health, of course, for you to deliver UHC, of course, it goes almost about 200, not less than 200 billion. And the resources all have to come all the way from those ones who are working from the private sector, the inputs from the government and other inputs from other players, the development partners. And once you have that, because if you are going to have a budget of, let's say, not less than 200 billion, of course, that's going to be almost enough resources which can deliver most of the functions on issues of health.
Dr. just to also look at the trends that show that there is an interesting trend that shows that maternal mortality is related to wealth and education. There is an interlink. We cannot separate these very key areas. What is it that you have done to use this to inform your interventions? Because wealth, education, and maternal mortality are related. How are we using this information to inform how we address this particular issue? Let me start with you, Dr. Ried. I know Senator.
In fact, you read my mind, but let him go ahead.
Oh, yes. Yeah, fine. On that, we have that information. And even when you look at the latest KDIGS report, I mean, the percentage of teenage pregnancy, the percentage of girls who get pregnant are the ones who are not educated. They are undereducated. They are below primary. So that is one thing. And you talked about issues of poverty. And one thing which is there is, of course, information. Because information and education is key, is a very key intervention, and that is why I mentioned about that we are doing. We are understanding adolescents. We want to empower the young population, because one other issue which contributes to maternal mortality is not going to the antenatal clinics, okay, not having proper preparation during pregnancy, and all this lies on the youths because they don't know. And that's why we're talking about antenatal clinics, because as we have said, excessive bleeding. So you can now imagine somebody who never had enough preparations to be given iron to build up the amount of blood in the body. Also those are some of the issues. The issues of nutrition also contributes onto that. So all these issues, first of all, the first intervention is information and education. And that is why now the issues of poverty comes in, because issues of poverty also, and I think part of it has been addressed through the Linda Mama.
Thank you.
Yes, but we still have the other issues of accessing. Like now, when a mother goes into labor, can she access the health facility as fast as possible? So we are talking about how many health facilities do we have? Do we have the referral mechanisms? And I want to urge the counties, wherever they are, we would like to have a functional referral system where we don't have to have an ambulance seated, being packed in one place. It has to be a fleet where the driver is always on the move. And I think that is having a strengthened referral system is very key, because we are talking about delays.
In fact, I wanted to say what you just mentioned, that education, wealth, and maternal mortality rates have a direct relationship. Listen to this. The KDHS 22 report that came out indicated that 33% of women own a house, who are 5% do so alone, then 28% who own it jointly, they own it with their spouse. Then 25% of those women own agricultural land. Only 7% of those women own an agricultural land. What does that tell you? For poor women who do not have access to wealth, for them going to these health centers, it's a luxury. So they would opt to use traditional methods, which sometimes are not of very qualified practitioners, that lead to to deaths prematurely. So I wanted to say that when you look at the issue of wealth, education, and maternal mortality rates being directly related, women with maybe pieces of land are able to have a collateral and can get loans or secure finances that would otherwise improve the economic status. But for poor women in those rural areas, they are competing between going to hospital or feeding their children. So surely you actually look at most of the women who are dying in this when going to deliver, women from those rural areas, because they are not able to access some of these services. So they are opting for traditional methods, which in turn are affecting them hugely. So maybe this is also something we need to look at. It's also showing the level of inequalities we have in this country and generally sub-Saharan Africa compared to our colleagues on the other continents. Yeah.
Okay, but Senator, when you talk about the poor who are less privileged and are unable to access the care that they need, therefore opting to deliver at home, isn't it the responsibility of the government first to cater for their needs? And then second, where does this place public institutions, for example, investment and putting up in public institutions, hospitals in this case to be specific, that cater for the need? I'm looking at some of the issues that had been cited in that report. 80% of maternal deaths in Kenya are due to suboptimal care, lack of proper equipment, supplies, or skills, to disrespectful treatment of patients, in this case, early pregnancies and the likes. So when will there be proper investment in public hospitals? One. Two, isn't it the responsibility of the government to look after Kenyans who are less privileged or come from poor households to access care when they are pregnant, and in this case, women?
Surely I agree with you, and I appreciate those challenges. And probably that's why this time round the government has given leeway to have an additional 20,000. But you also see the 20,000 might not cater for all the needs. Like I mentioned, we have ideal situations that surely we would want to see, but we have the realities we are facing, and Kenyans have to brace themselves for the tough times. But I do not think this is going to be lasting like forever. It's progressively, because yes, you want to do this, but it's not going to be instant, because as you well know, we are competing, especially when it comes to resources and funding. The other issues which are coming in, we're just coming from the COVID-19 period, so most governments are getting on their feet. We just had elections which you know, I didn't want to go to this direction, but the handshake government that we just came from was a bad leadership experiment we had in this country, because some of the issues that were being done, there was mismanagement of resources. I'm not saying we are saints, but we are picking up from a very bad experiment we had. And going forward, my brother, we note those challenges, and clearly, as I've mentioned, most of those ordinary people in those rural areas are not able to get those services because of the minimal resources I've mentioned, competing with other areas, because we are not just dealing with the issue of health. There are different sectors which are competing for these resources. Somehow you have to strike a balance to accommodate all these interests.
Okay.
All right, Dr. Godia, if you read from what is coming out of this conversation, there seems to be several factors leading to the increasing rates of mortality, you know, maternal mortality, that go beyond just the causes that we listed earlier. I don't know from where you sit if you have read the same correlation that I cited earlier, the wealth, education, and even bringing at this particular point, the uptake of contraceptives also sort of like has a correlation with the economic status of the woman and the education level of the woman. I mean, what do you read from this?
Yeah, so very true from what my colleagues have said in relating wealth, health, and education. And also, especially focusing on primary health care. In primary health care concepts, we say that if all the other sectors don't work, the health sector is the one that will suffer. Because if we don't take if our children don't go to school, if they don't have an education, then you'll find that the ones which are having the poorest of the poorest indicators. So they will not have the information and the knowledge, or even if they are given the knowledge, the ability to comprehend that knowledge and put it into practice, and maybe saying, okay, now I can use a contraception if I don't want to get pregnant. Or when they have a child, they're able to have that information and take that child to the hospital for immunization services, and also be able to access a health facility, plan for antenatal care, plan for a delivery, and in the end know that in future when the time comes for delivery, I will go to this hospital, and this amount of money that I need to put in my pocket to help me move from my house to the facility for delivery, because there's a cost in that. So there's a significant correlation, and that one nobody can dispute. The statistics speak for itself. And you find that people who are, or girls or families or people who have secondary education or more than secondary education, they are more likely to take up these health interventions, starting from what I've just said earlier, accessing healthcare, taking your children for immunization, making sure that you are yourself vaccinated for the major illnesses, and accessing other healthcare interventions that are required. So we also just have to understand our country and know that we are not homogeneous. We are not a homogeneous country. And also looking at the indicators, some counties are doing very well. Other counties are doing very poorly. So you'll find some counties have high teenage pregnancy rates than other counties. Some counties have higher maternal deaths than other counties. So the interventions also have to take that into consideration and know that if I'm coming from a county where there is the maternal mortality is high, what would be the interventions for that, or what would be the main reason of those deaths? And then this calls for targeted interventions, because now we can't have. Of course, there are some interventions which would be common. Let's say what we said, excessive bleeding is a cause of mortality across board. But coming to things like home deliveries, access to healthcare, availability of infrastructure, the counties are also at very different levels. There are some counties where you have to walk very long distances to get to a health facility. There are others where the tarmac, the whole county is tarmacked, and so moving from your house you go to a tarmac road and go to a facility. But there are some where you have to use a wheelbarrow or a bicycle to move from one area to another. But still, some areas, even that wheelbarrow, it has to be carried. Yeah, because the road network is poor. So we have to put that into consideration even when we are allocating resources. There was, I'm not an expert in this, but I know there was the equalization fund, which was being talked about by our politicians, or our parliamentarians. So I'm not sure how that has, how counties have tapped into that, because if your county, if we have to address equity across board, then you are saying that if I am in Nyeri, for example, and I'm going for healthcare, I should get the healthcare that I deserve. And still, if I am in Samburu, for example, and I go to a health facility, I should get the same service.
Okay.
But you find that is not the case, and the addressing mortality, maternal mortality, or any other health issue, the counties that, since we are looking at national average, the counties that contribute most, you'll find there are specific counties that are contributing most of the deaths.
They bear the biggest burden.
Yes, they bear the biggest burden. So we need to,
interventions is key. Not just interventions, but county specific, that touch on what the county needs in terms of addressing this. We're just about to take feedback from our viewers, but very quickly, just to add on to what she has said in terms of the contraceptive uptake, because this is one of the interventions to curb the high rates of mortality. The target is to have a one-digit in terms of the uptake, just in terms of those who have not accessed contraceptives, to be just one digit by 2030. Are we getting close to that?
Thank you very much. Concerns the issues of contraceptives, and we would like to call it family planning products. And why we are saying that is because we would like, therefore, as part of reducing unwanted pregnancies and spacing, and the women to space their children, because spacing the children also makes the woman strong, and actually, in a way, reduces some of these maternal mortalities. So one thing which is happening is that as a country we are doing well. We are now at the contraceptive prevalence rate of about 60%. Modern is about 57. The natural, traditional, and all the other ones about 5%. So we are doing well, not so bad. But we still have the unmet need, which still stands at 14%. And as a country, we would like, therefore, to make sure that in the next few years we have reduced that unmet need to one digit. So that is part of the issues of also making sure that we reduce on the issues of unwanted pregnancies and abortions. And so on the same note, as we do that, talking about equity and other programs, of course, once issues of UHC is addressed, then I'm sure it's going to address a lot of issues on finances, on equity and accessibility. And the other thing which I would like also to mention concerning this is, as I had mentioned earlier, that information and education for the youth and the young girls is paramount. And we would like all the other players and to design programs so that which will address the youth, because information and education is key. They have to be given the right information. And even from where I sit, we are already developing what we call parental guardian guide.
Okay.
We would like the parents to have confidence in talking to their young girls and boys, because that is a paramount interventions which is very key, and it will go a long way.
All right.
Thank you.
All right. So we asked you to be part of this program. We asked you to share with us your thoughts, your questions, and your opinions. And of course, right about now, we just want to sample some of them as we come to the tail end of this particular segment of the program this morning.
And here's what you're saying on Twitter. Babu Michel says, most public health policies like Linda Mama Initiative should continue no matter the changes of reigns in government, because their main agenda is to better our healthcare in general. Most of these policies are not political.
Okay, Bob Otieno Owino, the government should work in hand with midwives who many poor Kenyans turn to because they can't access or go to health facilities due to poor services and taken after complications which leads to death.
Godi Barasawere says the Ministry of Health, under the stewardship of Dr. Susan Nakhumicha, should implement the primary healthcare master plan that will in return ensure that issues like maternal healthcare are well taken care of.
And Ken_Muriti 1, the Ministry of Health, Kenya has not addressed the issue of safe medical abortion. Dr. Serem must live to the reality of untold deaths of women from unsafe abortions, provide guidelines to having safe abortion.
Remy Butia says accessible health facilities, improving family planning, institutional delivery care, antenatal care, and referral systems that work will help Kenya overcome its maternal health barriers.
Engineer Lazaro, leaders should seriously address raising cases of negligence and slow response to emergency cases in some public hospitals. Very unfortunate to lose life just because of negligence from trained health providers.
And SAO says comprehensive sex education and access to contraception can help prevent unintended pregnancies and ensure reproductive autonomy. Let's support young people in making informed choices about their bodies and futures.
A lot of feedback there from you talking about pertinent issues. We really appreciate each and every one of you who took time to share with us your thoughts this morning. Of course, final round of final remarks from our guest this morning. Let me begin with you, Senator.
My final remarks would be, of course, we are going to still keep pushing for more allocation of resources to counties, because the Senate is there to protect the interests of county governments, and we have devolution so that services get closer to the people. I don't think as a Senate we want to go back to where we are making the county governments weak, but in as much as we are pushing for more resources to counties, mine is a request to the county chiefs to make good use of the resources that they have, because largely part of the resources we have are borrowed money. So the moment you're not using the money very well, you know, we are witnessing very many other issues which we should have avoided. So the county chiefs need to cut down on wastage, and then any people who are implicated in corruption issues, tough measures should be taken. Let it not be an issue of investigations and it just fizzles out. There should be real examples of a whip being cracked on such individuals.
Okay. Dr. Serem?
Yes. Concerning, there is one question you have been raised there concerning safe medical abortion. As a country, we don't advocate for that, and we advocate for giving information to the young girls and youth so that they can avoid sexual intercourse at all costs until the time when they are married. I think that is an intervention which we want to emphasize. And on top of that, what we are doing at the ministry is we would like to have all this information harmonized, and so that we can have targeted information to the youths. And we want to separate those ones who are adolescents, the less than 17, and those ones who are 18 and 24, because they have a right to different kind of information. On top of that, so that I may finish. So once we do that, then we will perhaps have gone away in preventing unwanted pregnancies, which is as a result of an, which we are now talking about an unwanted pregnancies. And because now when somebody mentioned about safe medical abortion, I mean, first of all, you prevent that pregnancy.
Yeah.
So on the same note, my point I also want to bring to the attention of in the efforts of reducing maternal mortality, we want to encourage the women who are pregnant to go to antenatal clinics and to deliver in the hospital.
Thank you.
Thank you so much. Dr. Godia?
Briefly.
Yeah, so I would say that let's have discussion around maternal mortality. Previously discussing around, before we started this project of reviewing maternal death files, discussion around maternal mortality even within amongst health workers themselves was a bit difficult, and there was a lot of suspicion. And there was the blame game. You're blaming so-and-so because the mother has died. But now we are advocating for, together with the Ministry of Health, the no blame policy. Let's have discussion around why these women are dying. Let's document that. Let's identify specific interventions that can be done at the facility level to prevent future deaths. And likewise, let's also embrace working with communities at their level. Let's embrace working with communities, because countries that have embraced the community strategy of organizing health services within the community, they have seen a reduction in maternal mortality.
Thank you so much.
Yes.
Dr. Pamela Godia, a public health specialist. We were also having this sit down with Dr. Edward Serem. He heads the Division of Reproductive Maternal Health at the Ministry of Health. We are also engaging this morning Esther Okenyuri, who sits at the Senate Health Committee. Thank you for creating time, ladies and gentlemen. Now, that's how we wrap it for this segment.
Yep, and we as well thank you for your contributions and the questions that you have sent on the hashtag Daybreak at Citizen TV Kenya, at Ayub Abdikadir, and at Safin_Achieng. She will be up next on Health and Wellness.
Indeed. Coming up next, you're talking about matters depression. A lot is happening in the world today, and many are battling mental health issues. We're going to be having a mental health advocate and a counseling psychologist, Anthony Njenga, to tell us how to overcome depression, the signs, what you need to do in case somebody you know or yourself, you find yourself in that particular position. Do stay for that conversation coming up shortly.
Good morning.